So everyone, I'm Dr. Patrick McCauley, one of the physical therapists here at Coastal Integrative Health. I don't know if you guys are familiar with the clinic. Some of the faces look familiar from around the area here. We've been here in this building almost 2 years now. We've been together as a whole company about 5 years. So we were in the Red Apple building before being over here. So I've practiced physical therapy about 15 years now. Been down in this area about 10 or 11 years. And I've always been intrigued by just the recovery with, especially the knee replacement surgery, because it's been an ever-evolving part of physical therapy, and there's so many advances in it where people are getting back to great function after having the surgery, which is a pretty intense traumatic surgery, but they get great recovery and great change in their function. And so that's what I thought over the years too. I've always talked to patients about what things they would like to know more about, because a lot of times they'll go through the recovery and they'll say, I wish I knew this about the surgery, or I wish I had this information beforehand. So that's where I thought it'd be good to kind of reach out to people who might be having the surgery, so you have a better, idea of what to expect and what things you can do to kind of speed your recovery up if you do have the surgery. Is anybody here looking or thinking about having the surgery, the knee replacement? Yeah.
Mine's already scheduled.
Oh, it is? Okay. Who's going to be the surgeon? Or?
Dr. Marushak.
Okay. Yep. Yes.
I already had it.
You did? Okay. You just want to see it again?
No, I just come from Lowell.
Oh, yeah. Very good. Yeah, it's a pretty common surgery in this area.
Oh, yeah.
I mean, see, when you're out and about, especially in like short season, you'll see a lot of people with the incisions over the knees. But people are getting back to high activity, and I think in this region too, it's a very active retired population. People are getting back to playing golf, pickleball, all sorts of high activity, walking miles on the beach. So I think it's a good sample just to see what you can actually achieve with having the surgery done.
Yep, yeah, whatever, you too.
And so the things we'll talk about are just kind of an overview of the knee and why the reasons are for the knee replacement, what happens during the surgery, some pre and post-operative exercises you can do which would be helpful, and then just some alternative treatment options too if you're trying to push off the surgery a little bit, just some things you can do in the meantime to kind of help kind of minimize some of the pain. So it's one of the most common procedures in this area and in the U.S. too, and it has great outcomes, like we said. So that's where it's becoming more common. The technique's been perfected, whereas like the surgery itself used to take 2.5 hours. Now it's down to like 45 minutes for most of the surgeons. In the recovery time, it used to be 6 months to a year, and it's really in that 2 to 3 month window where you see a lot of gains now. The full recovery still takes upwards of a year to get to the point where you'll see your kind of final outcome. But just the recovery time is a lot faster just because the technique's better, the pain management's better. And it was first completed in 1968, and then now there's about 600,000 per year of the knee replacements in the U.S. alone. So it just shows how prevalent it is. And I'm sure that this region has a higher per capita than most. And just an overview of the knee here. This is like one of the models, but it shows just how the knee, the main components involved with the knee replacement surgery are the femur up top and the tibia down below. The fibula, the bone on the side, isn't really involved with the surgery as much. They're replacing more of the top surface of the tibia and the bottom of the femur. And then it depends on the arthritis in the knee itself. They might have to do underside of the patella or kneecap. They might replace that part too. Sometimes they refer to it as a button. It's just like a different undersurface they'll put on it. And then with the incision surgery too, it's like, so they'll do usually a center incision. Some of the surgeons will do more of a crescent moon one just to avoid some of the soft tissue. But most of the muscle is not affected by it at all. It's just more the capsule around there, and then just the trauma to the bones itself. And when they do the surgery, like the ligaments inside the knee, the ACL and PCL, which you hear about in sports a lot with ACL injuries, those are removed as they cut those joint surfaces, and they rely more on the lateral and medial collateral ligaments on the side for a lot of the stability. And they keep advancing with the components that go in too, where the range of motion is so much better. It used to be like 2 or 3 different size components they had, and when I first got in the field, you'd see some were just visibly, it looked like they had the wrong size knee in, because they would go into the operating room with maybe 2 different choices. But now it's just so precise where it's just a great fit. You can't tell the difference from the surgical knee and non-surgical one.
Do they measure the knee before they cut?
Oh yeah, it's very precise during the surgery. There's different techniques with that, and they'll get it down, but they'll have a number of choices at the surgery itself. That'll be the most precise fit. And that's where the range of motion gains are so much better, where you see people getting back 120 or 130 degrees, which is the bend coming back and the full extension. And that allows you to do things like going back to sport or just to being able to do stairs much more easily. So this shows just some of the degenerative changes which would go on in the knee. So this would be like the area that's most affected in a degenerative arthritic knee would be the cartilage and the joint surfaces on both. So this first picture just shows more mild arthritic changes where the white, which is the cartilage or the cushioning between the joints, becomes more kind of corroded or worn down. And that would be someone with just more mild pain, stiffness. That would be like the early onset. That would be someone who could probably respond to injections, do real well with physical therapy too, just kind of modifying their activity, anti-inflammatories. The next one just shows more thorough deterioration of the joint surface, where it's wearing down throughout the whole cartilage. Even the underside of the kneecap is becoming more arthritic. That would cause a lot more catching, pain with going up and down stairs especially, because the undersurface of the kneecap would be grinding across the joint surface. And that's going to lead to more swelling, and then that's going to just cause more difficulty with bend. And this would show more advanced degenerative changes where the cushioning that we saw in the early one is essentially worn down and basically a bone-on-bone joint. And that's where sometimes you'll hear about people having bone-on-bone. If it's true bone-on-bone, like this x-ray here was from a patient where you can just see how that's just complete on, there's no cartilage or cushioning in between, and just the grinding that would go on continuously. And in that knee too, you can kind of see how it bows out to the side. And you might see some people where after a while the knee becomes almost deformed, either caves in, which would be like a valgus collapse, or it might go out to the side like a varus. That can cause, hip or back pain. We'll see people with pain down the whole side, and it really stems from that knee issue. And if you don't correct the knee, all those other areas will basically stay the same. And those are the patients that respond very well to it because it's so far along in advanced exercise, or the bracing's not going to correct it. But they can do drastic changes to realign and get a straight knee from that. Any questions as we're going along with that? And so when you think about when would be a good time or a good consideration to have a surgery, it would be a time where the knees become severely arthritic and deformed, like that picture we showed of the x-ray part. And this would be like a visual picture where the knee's kind of going out to the side. That would be where it's kind of curved out. Another time would be if it doesn't respond to kind of anti-inflammatory medications, or you just have constant pain and swelling, or if there's just kind of, it doesn't improve with rest, anti-inflammatories, or if they've tried physical therapy, injections, some of the Synvisc injections, if you don't get relief with that, then it's worth kind of considering. And that's one of the things I've seen too. People have said where they went like 10 years trying to just muscle through it, and they wish they had done it earlier. And they're walking with a deformed knee, and they say the pain's 9 out of 10, and they can't do a lot of activity. And within 2 or 3 months after doing the rehab or the recovery, they feel great. They're back golfing and doing yard work, everything they wanted to do. So when you have like the constant pain, it affects regular mobility. If you have to use a cane or a walker because of pain, if it doesn't change at all with like anti-inflammatories, those would be all times to consider it. And then the surgery itself, it's like I said, it's gotten so much quicker. It used to be over 2 hours, and now they're doing it in a much shorter time period. But that's where they're really taking off the surface of both the femur and the tibia. So you can see they use precise saws, and they'll get just the cuts and take off the different segments of the bone to where it looks like this would be the top part of the femur, and the tibia on the bottom is just a very flat shelf. And with that, they can get the precise fit. Like that's all done with precise measurements there, where it'll be just a perfect fit of the component right onto that end. And you can see in that second picture, they show the drill going down into the tibia there. And that's where they'll put the stem going into the tibia down below.
What's it made of?
Usually it's a metal component, sometimes titanium. There's different metals they're using now. And they use plastic for one of the spacers they show next. So this shows the joint surface being prepped with like the kind of cement type adhesive they use. It shows it on the bottom, and then on the component up top, it still shows the underside of the kneecap red and inflamed. That would be where more of the arthritis is. Then it shows the component going in the bottom. That's like the first part of it. And this is a model of one of the knee components they use. The metal would be the component down here on the tibia. It's that shelf that goes here, and they would tap that into the bone with the adhesive there. And then the top part is a curved one, which allows the knee to get the good range of motion. These components on the side would be your own natural ligaments that weren't affected at all with the surgery. And then so the next slide show the two different components in it. It shows the silver on the top one and the bottom here, so for the different metal components. And then they take the plastic spacer and put in between the joint. And so the spacer almost acts like the cartilage that is worn down over time.
Does that get worn down again?
It can, but it has so much durability now. They keep increasing the shelf life or the life expectancy of these. They used to say, 10 years. Now I've heard them say 15, 20. You know,
74, 84, 90.
Yeah, but you rarely see or hear about revisions unless there's some random, fluke thing. You occasionally hear of the components not adhering to if there's a problem with the adhesiveness not sticking. It can be just bone integrity too, where it doesn't take well, like the stem down below. They might need to use a longer one going into the bone. But it's usually pretty straightforward and then a real good fit. So this is an actual model from one of the orthopedic surgeons. So you can see that's a little more lightweight. The silver components there, I think, are plastic on that model. They usually have a little more weight to them when you hold the actual components. But that plastic liner in the middle is similar to what they use with it.
So did
Where's
you
the
say they-
adhesive used? Is that for this part, for the plastic?
No, for the metal parts, to get it to adhere to the bone, to make sure it didn't slide out.
Temporary thing? until
Yeah,
it
and
heals?
sometimes they go without it too, and just hope for the bone to kind of do a porous kind of fill into the stem. So each of the surgeons are different. Most of the ones I've seen here use a cement, some medical type cement where it adheres.
So did you say they removed the meniscus?
Yeah, because the meniscus is usually worn down completely.
Okay,
So that's when they take off the top and bottom of the bone. That's where the meniscus would be.
okay.
And then the ACL and PCL are also they're connecting the two bones, the end of the tibia and femur together. So those would be removed, but the side ones are still intact there. And so that's where the measurements have gotten so much more precise, where they can really gauge the motion you need. It used to be where some people had a real hard time getting the bend back because maybe they put too big a knee in and it doesn't get the good bend. But now it's like you see just much better fit in this area with most of the surgeons I've seen. So
What could go wrong with the surgery?
there's some with any surgery. There's the risk with anesthesia would be one. They use a tourniquet over the thigh just to help with the surgical procedure. I think that's why they can speed it up too, so it's easier surgery. So people get a little thigh pain after, but that's usually pretty mild compared to most. And with any surgery too, there's like the risk of infection, but they really keep that in check too with just routine medical care.
Now, I had the stem cell, and I think that really, I don't know, I didn't have anything to compare it to.
Oh,
but
yeah.
In 5 weeks, I was playing golf again.
You were, yeah.
In 5
Stem
weeks.
cell.
Mhm.
Yeah, see, that's like
After
the,
4 weeks, I was walking around in Costco thinking, I don't hurt anymore, because every step was painful. That's why
yeah,
I
so
let
you
it
saw
go.
a drastic difference from
Oh,
before and
yeah,
after, right?
absolutely. Mhm. But I don't know, I can't tell whether the stem cell I was told that it was going to help
Who did the surgery for you?
Leighton,
Yeah.
Dr. Leighton.
So that's one thing you're using with a lot of the surgeries, and it helps. I think that part's not covered by insurance typically,
It's
right?
not, but I was hurting so bad.
But
It's gonna help.
I've
Go
seen
for
people
it,
do
you know,
really
I'll
well with
do
it, and
that.
if it can help the healing like that.
And in 5 weeks, I was back playing golf.
What is a stem
What
cell?
stem
Right.
cell, what is stem cell? What
They
is that?
they take it from your own body, they'll centrifuge it, and use that to help kind of cellular function or cellular metabolism.
While you're in surgery, and so you don't do anything beforehand.
Right, so he'll inject that in the surgical area, so basically speeds healing. So it helps speed up cellular function so the cells can kind of recover and regenerate.
$700 or $800.
Yeah,
I can't
that
remember.
sounds
He
about
did
right.
tell me up front that the insurance would not pay for that, but That was the only thing I had to pay
Why
for,
don't
so it was
most
worth it.
doctors do that if it helps the healing?
A lot of them are doing it more, it's just that it's not covered. That's the one thing we'll talk about as an alternative treatment option is stem cell injections for kind of mild arthritic knees. People are doing that.
I've been getting injections.
Yeah, yeah. Yeah. And the last part they would do is just put the underside of the patella on the like the button on that, then just turn that component around. This one doesn't show the kneecap here, which would be floating in the middle, attached to the quadricep muscle. So once that's there, then you have the kind of full complete joint, and you get the great motion. So right after surgery in the hospital, it's usually like a 2 or 3 day hospital stay, and they'll try to get you up with physical therapy there right away. Trying to walk on it right away. You can put as much weight on it as possible. And really, you want to get it moving as quickly as you can on your own. And I think if you don't, people aren't familiar with it, they're afraid they just want to wait there till, the therapists come in or nursing. But, as soon as you have it done and you're awake and alert, you can try to get your leg moving, the muscles going, right away. I think that helps the whole recovery process too. So this shows the one patient where it shows the x-ray of the knee beforehand as well as his x-ray after it was replaced. So if you see how bowed out it is to the side, it had collapsed out to the side. And then the x-ray, 6 weeks after surgery, look how straight that is. He was walking straight, his hip and back pain were gone from walking. And just to get that normal cadence back, you can just visibly see just a nice space on either side where it's even, as opposed to before where it was collapsed and shifted. That's where I see like the amazing corrections with that part too, and that's why they have such good outcomes with it, because they can make such drastic structural changes that affect everything the whole way up.
Do people get partial knee replacements?
Some. I haven't found the recovery time to be that much faster. I found it to be maybe 2 weeks a little better, but it's still trauma to the knee, the incision.
I was told I just need a partial. My feeling is if I only do the partial, then what's the likelihood of the other side going?
Right.
So why not just have the whole?
Yeah.
Sometimes you get a
Thing.
second opinion. If it's just clearly one side, you can do that and do well with it.
Okay.
But if there's a chance of it deteriorating, if both of them are saying, no, partial's all you need, then
Okay.
that'd be reasonable. It's worth just getting a second opinion sometimes if it's,
Right. All right.
because the recovery still, is a good two
I
to
mean,
3 months.
If
I
it's the
find.
same recovery, I might
Yeah.
as well just do the whole
Yep.
whole thing.
What is partial?
They might just do like one half of a component on one side of it. Like if just one part of the knee had been severely arthritic, if it was just bone on strictly one side, they would just do one half of what we see here, like one silver on one half and one component on the bottom.
Okay.
And you're saying the recovery is the same
Pretty
no matter which
similar.
way you go?
Yeah.
Okay.
Maybe a couple weeks faster, but
All right.
people still start off and you wouldn't be able to tell much of a difference. They still come in with walkers and, just sore from the get-go. Yes, usually you'd go home to, have home physical therapy. Some of the surgeons are getting away from the home physical therapy now. Just some of the push from like Medicare and insurance carriers are cutting back on like how much they're covering too. And they're finding that it's better just to get people in an outpatient clinic faster and really get moving. Sometimes just the home therapy, they might do some exercise or some walking, whereas in the outpatient we try to get a lot more hands-on to get the joint moving as quickly as you can. Because what you don't want is a stiff knee. It needs a joint, you want to get it moving. So that's where the more active you are in your own recovery, it's really critical too. A stiff knee is going to give you more trouble than a knee that moves well. And so what I put here is just some pre- and post-operative exercises. These are good if you're going to be having a knee replacement. These are things that would be helpful to do beforehand. They're pretty similar to the ones you'd be doing right after. And they're going to help increase muscle activation, the range of motion in it, and it'll help you with the first couple days of recovery too, just to get that confidence of what things you can be doing. So the first one is a quad set exercise. It's basically with your legs straight. You can put a towel roll underneath of it, and what you do, you just tighten the thigh muscle, squishing down into the towel. If you can see there, the middle part of the thigh is contracting. So you're just squishing your knee down into the towel there, and that works the medial part of the quads there. That's an important muscle to get full knee extension after the surgery. It also helps work in the range of motion. So this is something you can do, 20 or 30 times throughout the day, multiple times. just laying on the couch, put a small cushion under your knee and just squish it straight down. And you should feel that thigh muscle contracting. This would be something too, like after the surgery, if you're in a hospital bed waking up, you can start doing these right away. Even if hooked up, drains, whatever, you can wake that thigh muscle up. It'll make the moving out of bed that much easier. Because with any kind of surgery, even with hip replacements or knee replacements, the quads kind of get inhibited by the surgical trauma, meaning they don't fire as much, and you can get weak pretty quick, where the leg, you just won't trust it as much. So the more active you keep it, the better it'll be. Ankle pumps are another one. That's just another good thing. This is good in general for circulation. When you're sitting on the couch or laying in bed, just pumping the ankle back and forth, doing 20 or 30 at a time. And you could do these every hour. Same thing, these would be good to do before surgery and right after in the hospital. It's good for circulation. It helps ankle mobility, and it also helps get that knee fully extended or straight. Another good one is a straight leg raise, and that's just keeping one leg straight, bending the other leg to support your back, just raising it up about a foot high and then lowering back down. This would help strengthen the hip muscles, because right after surgery too, the leg's going to feel real heavy just from the swelling, the trauma. So this would be good to practice beforehand, because in the hospital bed it's tough to lift the leg when it's swollen, just been surgically worked on. So the more you're doing this before the surgery, it's so much easier for people to move and kind of position their leg in and out of bed. This next exercise is called the short arc quad. It's where you take a ball. You could use a rolled up towel too, but it's just doing the end range knee extension, just letting the knee bend a little and then kicking it up straight. And that also works the quad muscle. Every time you step, you want to have your legs swing through and hit with the heel as you're walking. So that's where the quad helps get that end range knee extension. So that's where that exercise is helpful, to make sure you can get that leg fully extended. Because what you don't want to see is people favor limping too much, where they're walking foot flat, they're not getting their knees straight. If you don't get the knees straight early after surgery, it's harder to get it down the road, and it just leads to more pain and difficulty. So doing these things beforehand just help make sure you get the full motion after as well. A more full version of that would be the long arc quad. It's just like sitting in a chair on the edge of the bed, just trying to straighten the knee fully. That's going to work the quad throughout the whole range of motion. The other part shows using a strap. Like if you can't get your leg all the way straight because of pain or a little stiffness, use a strap or a towel to help pull it all the way so you can get that full motion. It's a simple way to guide the motion. It can be helpful too after a surgery, getting in and out of bed or positioning by using a strap or a towel. But that's something too, if you had surgery and were sitting in the hospital room, waiting for therapy or just taking a break, if you had your leg over the side or once you're at home, use a strap, help guide the range of motion. Like you don't want to let it get stiff. Like you said, the knee's a joint you want to get moving, and if it's guarded or protected, it's just going to tighten up, and then the recovery is so much more painful. If you just get it moving that early part of recovery, the whole rehab is so much easier. Like when you come into therapy, it'll be so much easier. Like I see some people come in and their range of motion is like, maybe like 50 degrees of bend or 60. You really want to have 90 degrees when you come into outpatient. It just makes the pain that much better. So that's where that exercise would be helpful there. Next one is a calf stretch. Just using like a strap or a towel with the leg straight, just pulling the foot up towards you, and that stretches out the calf muscle. Holding about 15-20 seconds. That helps also work to make sure you have good ankle mobility and just get the knee is fully extended. And a big thing too, people say aside from the legs, trying to get the upper body stronger too. If you're not used to using a walker and you have a surgery, you're going to be using your arms a lot more than you're used to, because you're going to want to favor the leg some. That'll be a natural tendency. So you want to get the arms used to kind of bearing weight or pressing as you go into the surgery. So that's where a couple different exercises are helpful. The wall push-ups one, that's just going against a wall or a door. Just arms about chest level, shoulder width apart, just leaning in and then pushing your body weight away. That'll help develop some strength that you'll use for bracing on a walker. The more advanced version of that is a chair push-up. And that's a good one to try to practice at home, just using the arms of a stable chair, just trying to press up like you're starting to stand and then lower back down. If you have shoulder issues, I'd kind of hold off on that one if it's too painful. But that is a good one to really get the extra strength you need for getting up and down. And then if you're going into surgery, it's always good to practice how you're going to get up and down, after the surgery. So right after surgery, you're not going to want to use that leg as much to help. You're able to use as much weight as you can, but it's good to practice getting up and down, really focusing on one leg and both arms doing the work. So like in this video, Courtney was working on getting up. The right leg would be the surgical one, where she used more of her weight on the left leg. So it's good if you just practice at home, sitting in a chair, use one leg, whatever leg you're having surgery on, just put it a little in front of you, and then just practice getting up with using the one leg and then your two arms till you come upright, and then grab the walker. The more you do that beforehand, it'll be easier. You don't want that to be the first time in the hospital where you're just trying to get up that way. So I think if you do it a few times, it'll be second nature. You'll be able to pop out of bed that much more quickly.
Do you have these in our handout?
Yeah, that's what I'm going to print out some of these, and you can email some. And we're going to put some of these on the
Email's
website, a
fine.
whole video.
Email's fine.
Email's fine, yeah.
Yep.
Then some other treatment options, like we said, if the injections have failed, some of the things with the stem cell that some surgeons are doing or doctors are doing, there's some different ones where they'll do it kind of preoperative or preventative care, where they'll take stem cells, which go into the pelvis or the ilium of the pelvis, the top of the hip bone, and draw stem cells from there, and then they'll centrifuge them in a spinner and then inject them into a troubled joint area. And that's not covered by insurance. It's usually, that's a more expensive procedure. I think $5,000 or $6,000. There's a few. One of the ones was Dr. Yergin. He used to be an orthopedic surgeon. It's a regenerative medicine. But they do that all in their office, where they do this draw and then inject, and then it helps calm down inflammation and kind of promote ligament and cartilage kind of regeneration on a slight level. If someone's got bone on bone or full degeneration, it might calm it down some, but you're not going to correct the advanced arthritis. But it is something, if someone's like on the early stages, they're still working, it's like a viable option to help kind of manage the pain and kind of prevent it. Another thing we have here is cold laser therapy. I don't know if you saw the flyer out in the lobby, and that's been pretty interesting. I've used it on myself for injuries too. That uses light waves to kind of penetrate deep onto the cellular level, and that helps basically like mitochondrial function, which is like some of the cellular function, basically cellular metabolism. It just helps the efficiency with cells function, which is basically by using the laser, it helps the healing process. And at the same time, it'll lead to some vasodilation, so there's increased blood flow to the area, which can help in the healing. It brings nutrients to an area and can help flush out kind of toxins or waste from an injured area. So I used it with a running injury. I'd fallen during a race and landed on the knee. It was real inflamed, and I did a few courses of it. And I did about 5 courses over 2 to 3 weeks, and it really calmed it down. So it's from personal use, I found it helpful. It's not a cure-all too, but it helped me do another race like 2 or 3 weeks later, when it might have taken another 3 or 4 weeks. But I found that people are doing that if they're going away on a trip, going to Europe, and they want to just calm it down a little more. That's a viable option too. It doesn't correct the bone on bone or anything like that, but it definitely helps the symptoms, for more like the early stages. I had brochures on that too. And if anybody wanted to try that ever, we were saying if people came to this and wanted to even see what the laser's like, we can do like a free demo if we're coming to this. It's usually like $50, not covered by insurance, but if anybody wants to try that, there's one thing possible too. Any questions about any of the stuff we've gone over there?
I like the exercises.
Yeah.
Yeah.
That's good.
Does Novant have a good reputation, Novant Hospital?
Yeah, I think the hospital's been better. I mean, it's
Has it been better?
no, people used to have, like when I first moved down here, not the best reputation. I worked there for a few years, and then with the new hospital, it's done well. And Dr. Layton operates out of there. I think Dr. Marushak does still, right?
Dr.
Yep,
Kelso?
that's
And
what
some
I'm
of them are
having
down
done.
at Dozier, so yeah,
Dr.
Kelso,
Kelso.
Marushak.
Yeah.
I love that hospital. My husband was
okay,
in there for
good.
2 weeks and just couldn't say enough nice things about
Okay,
Yeah.
the
that's good to
hospital
hear.
itself.
So that's what
The
people
nurses
say. It was
are
like a smaller
fabulous,
country, but it's like you
surgeons
get
are
more
good.
personal care
That's where-
a lot of times.
Okay.
Yeah, I think they're great.
Yeah.
If someone gets a staph infection, whose fault is that?
It's just by chance too. It can be
Okay.
on I mean, we all carry a lot of things on the surface of our skin.
Okay.
I think the hospital is just notorious in terms of places where that can happen. It can be in the home setting too. I mean,
Okay.
So what about the machine that the doctors use?
some of them use it, some don't nowadays. Like
Yeah.
Dr. Layton, I think, still uses it. Some of the other ones don't use it anymore.
So I'm by myself, so he said that the best thing for me would be to go into a residential rehab for 2 weeks.
Okay?
And that sounds good to me. I wouldn't have to cook dinner or anything.
Yeah. Yeah, like that would make sense because if you're on your own, it'd be hard to get around with the knee then.
But then he said I'd have to have someone with me for 2 more weeks. So that kind of,
What knee you having done?
Not.
The left? Yeah, you'd be able to drive with, since the right one's not involved.
right. Well, he said I would be taking pain pills and I wouldn't really be able to drive.
But Dr. Layton does use the machine, and I found that you can push yourself more with the machine.
Yeah.
Because you can keep dialing it up, so you can keep making your leg come back more and more and more. I mean, the first couple times it does it, it hurts a little, but then,
Can regulate it.
yeah, you can push yourself more because you just do.
Why do some not like the machine?
The long-term studies are kind of mixed as to the range of motion gains at like 2 or 3 months out, whether you used it or didn't use it. So that's where they're saying it's not proven either way whether it's beneficial or not. So I think some surgeons have used it and they think that that's what helps the most early on.
If it is your right knee, how long until you can drive?
Probably closer to 4 to 6 weeks.
Okay.
But some of it is the pain medication too, as well as the pain itself.
But she said she didn't take any pain.
I just had it for a couple days, pain medicine.
That's what I mean. That's what I've seen with a lot of the recoveries now. The pain's so much lower than it used to be. People
Well,
can
according-
taper off the medication.
According to Dr. Layton, women do a whole lot better than men.
That's true. That's in general in physical
That's
therapy.
surprising.
Yeah.
Yeah.
Better pain
But I went in
tolerance.
with the attitude, I was excited, I couldn't wait to have this done,
gosh.
and I really was, I was excited to have it done, and I was so glad, I would do it, I would have my other one done in a minute, as soon as it needs it.
Yeah.
I wouldn't hesitate.
Is there a reason that you see people using walkers as opposed to crutches?
Walkers are more stable. I mean, so you can brace your arms.
Crutches give you pains over
Yeah.
here.
Yeah, it does.
Well,
Big time.
I've done crutches, I'm good at it.
And just if one slipped out, it's
Yeah.
easier with the more security with the walker. You can get back to more of a normal gait pattern, I think more upright with the walker. Even if you use just your hands to glide on and barely used it, if you're feeling good enough to advance it.
Okay.
Yes, I used to think crutches are good too, but I just find the gait pattern so much better just using a rolling walker. And you might be someone who could just kick it in like 2 weeks, be on a cane, or even
Yeah.
before that, depending on the pain level.
Okay.
Can you play tennis after a knee replacement?
You have to be careful with the jumping type activities. People play doubles tennis after. I've seen that more. I mean, doing full court tennis is tough on.
I'm talking about doubles.
Yeah, I've seen people do that. Get back to that. Yeah. And some of the surgeons have different guidelines for what they want people doing after, just to decrease the risk of re-injury or. Any other questions about that stuff, though?
You gave us a lot of good information. I don't really want to see what's actually
I
being
know,
done.
I'm with you.
This is a nicer picture, right? That's
There you
what
go.
There you go.
So I'm going to forget that part of the lecture.
Yeah, I like the exercises before.
Yes, we'll post those videos onto the website too, and then we'll have some email with the different exercises. We can shoot those over as well.
Right, that's good.
But like the basic ones, like the quad sets will be good. That's tightening the thigh. The straight leg lift, ankle pumps. And these are all ones you can start doing. Like, when is your surgery going to be?
October 2nd.
Yeah, that's plenty of time. I mean, that'd
Yeah.
be great if you start doing these.
Yeah, I'm already kind of doing that stuff.
Yeah, it just helps. It's second nature. So I mean, because you don't want to rely on the therapist in the hospital because they're mainly just getting you up, moving quickly. Some of them might not even go over the exercises because they're just trying to make sure someone can bear weight, that they're not getting lightheaded or orthostatic when they're up. So it's kind of the onus is on you. That a lot of times the surgeons will give packets or handouts of these are the exercises you should do. But I think it's helpful to do this stuff beforehand too, so you're already in the, you've already learned it. Don't try to learn it after the surgery.
And it strengthens your muscles to
Yeah.
do it, to take the place of the knee.
Yep.
You do the therapy here then, after the surgery too?
Yeah, we do it here. We have like 4 different therapists now. We do all one-on-one therapy here, so I think from my standpoint, I think we get good results that way because you can spend more time. We focus a lot of hands-on time too. like we have the common gym area here, and we have all breakaway rooms for more privacy too, as we need for like different hands-on stuff.
Well,
Hope that didn't scare you off. But it's the drastic change after the surgery. I mean, it's remarkable from what people do before to what they can do after.
well, actually, I was scared before, so maybe you've calmed me down a little bit. That's why I've been, not contemplating it right now.
Yeah, and then the more you take an active, engaged role in the rehab and the preoperative stuff, it'll definitely help. If you just start chipping away at this stuff now, it'll become so much easier. As soon as you had the surgery, get moving with it.
I have a question.
Yeah.
With the gel shot, okay, if you decide to take that and then a couple of months later decide to have the surgery, is that going to hinder you from having the surgery taken?
I don't know what the time frame is. Sometimes there's a little time frame more for cortisone shots with surgery.
Mm-hmm.
Like the gel shots, sometimes there's much time in between.
I had them, it didn't work.
I had them, it didn't work either.
Well,
Yeah.
mine's been working.
Oh, you're
so
lucky.
That's why I've been taking it, but.
So did everybody get their email in here who wanted the exercises then?
Yes.
Okay.
Well, thank you very much.
Thank
My
you.
pleasure.
Thank you.
And then there's
That's
brochures
great.
on the laser here, and my cards are here too. If you have any other questions about it, don't hesitate to email me. If somebody wanted to try the laser and you said you came here, that's fine. We can just do like a free demo of it. Like I said, I use it personally. That's where I found how it works, especially for an acute injury. Like if you had something where something was acting up and you wanted to just speed the recovery, it's pretty neat to see. I hadn't seen much of that in grad school, so it's kind of a newer, advanced kind of technique they have.
Well, Sue Roberts is our neighbor.
Oh, yeah.
That's how we got here. so-
Oh, very good.
Yes.
I said, go do it, just do it. It's
Yeah.
great.
All right, well, thank you very much for coming, guys.
Thank you.
My pleasure.
It really was a good thing.
And I'll get those, the exercises out in the next couple of days too.
Terrific, thank you very much.
Yeah, my pleasure.
Appreciate it.
You ready for your surgery?